So good evening guys. If I'm visible and audible, give me a thumbs up, everyone. Okay, so good evening guys. So give me a thumbs up if I'm visible and audible. I can't see the messages. Somehow or the other I'm unable to see the messages. Just a second. Okay, so Dr. Sushma, right? I do get it. I do get your this thing. So let's start with the session, guys. Right. So Dr. Sushma did message, and let's start with the session, everyone. Okay. Okay. So good to have everyone around. We'll just wait for some time so that everyone joins in through the session, and then we'll continue with the session now. Okay. Again, this is an MCQ session, guys, for YouTube. We'll be discussing MCQs and some concepts based on that. Okay. So let me start by introducing myself to you. My name is Dr. Vinish Srivastava. Presently, I'm the head of the department and associate director in anesthesia and critical care. I'm working with the Fortis Lapham Hospital in New Delhi. Prior to that, I worked as a senior consultant here itself for the last 10 years. So before becoming the head, I worked as a senior consultant here itself at Fortis Lapham Hospital for the last 10 years. Prior to that, I was at Maulana Azad Medical College. I've done my senior residency from Maulana Azad Medical College, and I was also a specialist over there. Prior to that, I was at Deen Dayal Upadhyay Government Medical College, not college, but we'll say hospital, government hospital. I've done my DNB secondary from there. Prior to that, I've done my DA and FCPS, that is from Grant Medical College, Mumbai, JJ Hospital. Before that, I've done my respiratory medicine. I'm also a qualified chest physician. I've done that from Lokmanya Tilak Municipal Medical College, Sion Hospital, Mumbai. Before that, I've done my hospital administration, and before that, MBBS. So that was a slight introduction about myself. And as with every class, I tell everyone, apart from clinical duties, keep a hobby. For me is playing the guitar. Here I'm playing on stage. I'm playing with a local folk band. Also been teaching students preparing for postgraduate medical entrance exams and FNG exams for the last 10 years now. Now associated with Unacademy. Okay, so since this is a YouTube, so for all the people who are on YouTube and don't have the app, download the app. You need to use a code to get inside. You can use any code that you have. All right. So as soon as you download the app, once you open it, you get plus free courses or special classes. So depending on what you're preparing for, this is for those people who don't know. I know a lot of people already have the apps. It's not for them. People who don't know, plus is the subscription based courses. All right, for people who are preparing long term. All right, special classes are the ones which are free, like one of them which I've taken today. This is more to do with MCQs and discussions. So people who are already prepared and they just want to revise and see their MCQs and discussions and concepts, it's okay to go for the special class where you have the free classes. Absolutely, it's not subscription based, and we keep on holding them, time and again. All right, for all the subjects. Subscription or the plus is basically, I'll advise for those people who are going for long term or who are still preparing. Okay, so going forward, once you've downloaded the app, guys, so remember, plus is the subscription based and special classes are the ones which are totally free. Remember this point. All right, so special classes are just the ones like plus. We have interactive sessions live Polls are there just like the plus class. You raise your hand, there you can ask a question directly. Don't miss a class. You come to know that lecture notes are there, and anywhere, anytime. All right, you can do that. Plus subscription, I told you, is the one which is subscription. As I said, this is for long-term preparation, people who haven't prepared, where you get access both the live and recorded classes. All right, all of us are teaching over there. You get live tests and quizzes. You can study on the device of your choice, and the question bank is available with lots of questions and their explanations offered onto them. Similarly, beyond the plus is something called as Iconic, where you get Unacademy and Prep Ladder both. Okay, that is what is called Iconic. So there are two things combined into Iconic. All right, that's a subscription based again. This is where we get complete courses. This is one of the feedback from the courses which we have done. All right, so this is where we complete, the complete course. The question bank is highly effective. There are lots of questions and with explanations. All right. So as I was talking about plus and Iconic, this is how you go for it. Either the subscription based, which is plus, or Iconic, and depending for the duration that you want to go for. As I said, this is more important for people preparing long term. If you want to revise, even the special classes are good enough. Okay. So congratulations to all the toppers for December FMG exam. They have done pretty well. And this is the only platform that we can wish them for and congratulate them. All right. Remember, there's a new feature called Raise a Hand where you can ask questions directly in the class when you download the app. Okay, so your doubts get absolutely cleared over there. This is our free test calendar. Please note it down. There's a free test that you can take part in. You just have to unlock with a code, and then you can take part in these MCQs and you can see where you stand. This is free. Okay, remember guys, keep it in mind. These are the subscription based batches now starting, and we're starting it tomorrow onwards. So I'm going to take up anesthesia within 6 hours now. I'll try to finish off ultra fast revision as the name suggests. Ultra fast revision batch. We'll try to concentrate and finish it within 3 days anesthesia. Okay. Apart from that, you have the focus FMG batch running and target NEET PG batch running as well. Okay. So a special offer for the Republic Day, as you can see today, it's 6 months free extension available. All right. So this is available for all the 1 year and above that plus subscriptions. You have to use a code here, guys. Okay. Any code that you have. So do follow me up. The last point before I start with the MCQ sessions. The reason for following up is so that you come to know when our next classes are held, and it is not because we have targets. As I said, you can see people just message us. Can I help you in completing your target of subscriptions? I always put this in my class just to let everyone know as to this is how sharks are roaming around, and this is how we answer them. Okay, we have no targets. We teach because we enjoy teaching, because the students pick up PG and anesthesia by their choice. So the aim is not to reach subscriptions, guys. Please let me be clear about it. Okay, there's no goal. This is exactly why we are teaching. Okay, this is one of the students who's got amazing result, amazing marks. All right, and this is the reason why we teach, and we keep on teaching again and again. Okay, again, this was about NEET PG. This is about FMG. This is the reason why we teach, guys. This is the reason. Okay, so let's start. I think a lot of people have joined now. Thumbs up, all of you. Shall we start with the MCQs? Okay, so remember that's the code, and let's start with the MCQs. We'll have discussion based on that. As I said, my questions would be more, rather than having 100 questions in these 30, 40, 60 minutes, we'll be dealing with less questions. We'll be discussing with some concepts and as to how the questions are framed, as to how to answer the exam answers as well. So let's start. During the CPR of a child, chest compression to ventilation ratio is, so 15:1, 15:2, 30:1, 30:2. Please mark your answers. Dr. Akhilesh gives a thumbs up. Let's go forward. Please mark your answer. I mean, of course, we don't have the poll because today itself I took a free class, special class, and we took in the form of polls. Now here I can't have a poll, but I could have you people answering them. So please mark A, B, C, or D. What's the answer? Dr. Akhilesh has given one answer. Other people? So Dr. Sushma, other people? Any other answer apart from what Dr. Akhilesh has given? Yes. So Dr. Akhilesh, let's go to the question again and just read. Simple question, huh? So it's not even something great about it. It's been asked many times in the exam as well. During CPR of a child, Dr. Sushma says D. Right, Dr. Sushma, I was waiting for that answer. So Dr. Akhilesh, the correct answer here is D, 30:2. Okay. It is not 15:2. Remember, when you're talking of chest compression to ventilation ratio, remember everywhere it is 30:2 except for one places. And that one place is if you have a child but with 2 rescuers. Remember, in this question, nowhere it is mentioned it is 2 rescuer. Yes, Dr. Akhilesh, thumbs up. Is this point clear? Okay, see, that's how questions are asked in the exam. Dr. Akhilesh, is this point clear? So if we have to discuss about it, so if I have to just make a chart in the form of a chart, all right, so it will be like if there's an adult or if there's a child and there is one rescuer and when there are 2 rescuers. In case of an adult, 1 rescuer, it is 30:2. In case of adult, 2 rescuers, it becomes 30:2. Child, 1 rescuer is 30:2. However, guys, the only difference is child with 2 rescuers where it is 15:2. Okay, so remember, this is the only place. In this question, yes, child has been mentioned, but at no place we have mentioned 2 rescuers. Okay, so therefore, the correct answer here is 30:2. Had it been mentioned as 2 rescuers, doing the CPR, then the correct answer would be 15:2. A small word changes the answer like this. So I just want you people to keep that in mind. Now talking about a child, even if you're doing CPR for the child, remember the site of chest compression remains the same, which is the lower 1/3 of the sternum. Okay, lower 1/3 of the sternum is the site of chest compression. Whether it's an adult or a child, the site of chest compression remains the same. Now about the adult especially, they say the rate of chest compression is normally 100 to 120 per minute and the depth of chest compression is normally 2 inches to 2.4 inches or 5 centimeter to 6 centimeter. Okay, so these 3 are important points regarding the chest compression. Clear, everyone? So lower 1/3 of the sternum is the site of chest compression. 100 to 120 is the rate of chest compression, and 2.2 inches to 2.4 inches and or 5 to 6 centimeters is basically the depth of chest compression. Remember, this I am talking about in an adult. So therefore, you can't be depressing in a child 2 inches to 2.4 inches. So what to do in a child? Remember, the depth of chest compression is 1/3 the depth of the chest. Thumbs up, everyone. Is it clear? Is it clear, everyone? Okay, hopefully. So let me go and take the next question then. Okay, as I said, we will be discussing some concepts also. Here we discussed about the chest compression, the site, the rate and the depth. So let's go forward. All right. Also, one more thing. When you're talking of an infant or a neonate, in that point, the chest compression cannot be like one hand over the other. In that thing, it changes, guys. So as you can see, this can be asked as an image-based diagram also. So when you speak of infants and neonates, the CPR process that it is done, this is called as a thumb encircling technique because it is thumb is encircling. And second, another way that to do is a 2-finger technique. So when you speak of CPR in an infant or neonate, so it is a thumb encircling technique or a 2-finger technique. As you can see, if this is a single rescue doing the CPR, the chest compression would be 30:2. 30 chest compressions and 2 breaths. In case of 2 people, as you can see over here, it would become 15:2. This is the difference. All right. So let's go and take the next question. Now, a 56-year-old patient has to undergo glaucoma surgery under GA. All right. Which of the following should be avoided in this patient? So 4 options are given to you: ketamine, propofol, thiopentone, or none of the above. Yes? Yes, guys? So I'm just waiting as to the answer that I get from you. So Dr. Akhilesh says one answer, Dr. PK says one answer. Anyone else? Any other answer? Dr. Sushma says, okay, so I think all of you have given almost the correct answer, that is ketamine. Absolutely correct. Okay, absolutely correct. How to remember this point? Just remember, when you speak, glaucoma anyways has the intraocular pressure raised. Okay. A small way to remember ketamine in exam. Okay. A small way to remember ketamine in exam is that it increases everything. So when you speak of thiopentone and propofol, when you speak of their properties regarding the ophthal, so remember thiopentone and propofol kind of decrease everything. So propofol decreases the intraocular pressure. Similarly, thiopentone decreases the intraocular pressure. Just like thiopentone and propofol are going to decrease intracranial pressure, they're going to decrease the blood pressure, they decrease the respiratory rate. If you can see, CNS, CVS, RS, all of them, these two are basically working in the same proportion, in the same way. They all act at the same receptors, GABA receptors. However, when you speak about, or when we talk about ketamine, it works at different receptors. Those receptors are NMDA receptors because thiopentone, propofol were working at GABA. So ketamine becomes slightly different. It works at NMDA receptors. Its properties become opposite of that. So therefore, when you talk about ketamine, you will find that it increases the intracranial pressure. It kind of increases the blood pressure. It kind of maintains the respiratory rate. It's not causing so much respiratory depression. It increases intraocular pressure. Because it increases the intraocular pressure in a patient of glaucoma, I'm not going to use ketamine. Otherwise, propofol and thiopentone can be used safely. Thumbs up, guys. Is it clear? So Dr. Akhilesh says all receptors NMD. Absolutely correct, Dr. Akhilesh. Right? So that's how it goes. All right. So that's what we are discussing here. Nice. So hopefully this point is also clear. Let's go to the next question without wasting any time. Which one of the following produces a conduction block? 4 options. So you've got acetylcholine, morphine, thiopentone, lignocaine. Please mark your answers and then we'll discuss it out. So Dr. Sushma has given one answer. Other people? Dr. PK has given one answer. Anyone else? Dr. Akhilesh has given one answer. Anyone else? Any other answer, guys? Okay, so let me see. Dr. Sushma, you're absolutely right. When you're speaking of conduction block, okay, I was just seeing the messages that I'm getting. Dr. Akhilesh says, is it for the heart? That's what I'm coming, Dr. Akhilesh. I'm coming there. Wait. So what are we discussing about? That's exactly how questions come. So, excuse me. Just give me a second. I'm just coming, Dr. Akhilesh. Now, when we are speaking, it's such a simple word, conduction block. So, I'm saying which one of the following is going to produce a conduction block. Conduction. Ideally, I'm talking of a block that is going to be done by one of the drugs that I'm going to give. Is it thiopentone? No. Morphine? No. The confusion has been between two things, which is one is acetylcholine, which one is lignocaine. Now, the point is, can you inject acetylcholine to someone? Is it a drug? It is something which is given? No. So good evening, Dr. Paras. Good to see you. Okay, so coming back and discussing about the fact, lignocaine. All right. So lignocaine is what produces a conduction block. So conduction block का मतलब क्या होता है? Local anesthesia. When you talk of local anesthesia, how does it work? So when you've given local anesthesia, so how does someone feel the pain? For example, if someone has sustained injury, the pain is carried by the pain fibers. It goes to the spinal cord. From the spinal cord, it goes to the brain. All of you know that lateral spinothalamic tract, the fibers that carry are A, delta, and C. I'm not going to go to those details of that, okay? Lateral spinothalamic, you people already know all this. Now the point is, what is happening? How does someone feel the pain in the brain? The basic point is action potential gets produced. The action potential is what goes to the spinal cord. From here, it goes to the brain, and this is where the patient feels the pain, right? Perception of the pain is over here. You must have seen the pain pathway, which is again an important question. So when you give local anesthesia, what does it do? All of you must have taken sutures so many times. You must have taken, so many sutures in all your life, right? How does it work? So basically what is happening is, you people know, when action potential goes, so if this is the way the action potential is going, okay? So how does it go basically? When it's passing through the nerve, the action potential comes over here. Then this question has come in the exam last year itself. There is something called a sodium channel. So when the action potential reaches the sodium channel, the sodium goes inside and the action potential jumps to the next one. So that's how action potential has jumped. Again, this comes to the next sodium channel. It kind of goes inside and the action potential jumps to the next one. Again, action potential has gone forward. This next sodium channel, again, sodium will go inside. Action potential has jumped to the next one. Can you see? This is exactly how it is jumping and going to the brain. Thumbs up, everyone. Is it clear? Now, what is happening? This is exactly what is called as conduction. I give lignocaine to the patient. Do you see what has happened now? Once you have given lignocaine, this sodium channel has become blocked. Can you see? Now, sodium channel has become blocked. It's the same sodium channel you were talking about. But now it's become blocked when you give lignocaine. So the next action potential, as you can see, if I have to show it from here. So when the action potential is coming to the next channel here, now sodium can't go inside. Like how sodium went inside over here, sodium can't go inside. So the action potential does not jump forward, and that is the way when you give local anesthesia drug, the action potential does not reach the brain because this action potential is stopped here itself. Therefore, what is local anesthesia doing? It is preventing the conduction of the action potential. So therefore, it is also called as a conduction block or a propagation block. So therefore, the action of local anesthesia drugs is also called as conduction block, or it can also be called as propagation block, because what it is doing, it is preventing the local anesthesia or preventing that action potential from going forward, because once you give local anesthesia, it blocks the sodium channel. So this action potential does not go forward. So basically local anesthesia works at the nerve or the nerve terminal, and at the nerve it prevents the forward movement or the propagation or conduction. It prevents the action potential from moving forward. Thumbs up everyone, point clear? Any questions or doubts? That is how local anesthesia works. Dr. Akhilesh, is this point clear? Dr. PK? Any questions or doubts? This is the basic mechanism of local anesthesia drugs. Okay, that's how they work. Okay. Yeah, hopefully. So I got yes from all of you. Let's go forward and take the next one. All right. So this is how local anesthesia drugs work. Okay. So remember, lignocaine is what produces this conduction block or propagation block. It prevents that impulse from moving forward. It prevents that action potential from going forward. Where does it work? That's again a question. In fact, last year it was asked, local anesthesia works at which of the following? So they asked you sodium channel, potassium channel, calcium channel, chloride channel. MCQ question. This is last year NEET PG question. Okay. So the answer was sodium channel. Can you see? If you know the concepts, each and every question becomes much more easy to answer. All right. So let's go forward and take the next question. Hopefully there are no doubts over here. All right. So which one of the following is analgesic in nature? So there are four options: A, B, C, and D. Please mark, guys. Good. So I will not wait for more. You people have given me the answers. Absolutely correct. Analgesic in nature is ketamine. Okay. As I was discussing a while back, just a while back, I was speaking of thiopentone and propofol. So let's not take just thiopentone, propofol. Let's take even methoxytol. So methoxytol, propofol, thiopentone, and etomidate. So when you speak of anesthesia, see, we are preparing for exams. We are not thinking that all of us have to become anesthesiologists and we have to have an idea of all the drugs. Exam purposes, when you talk of IV induction drugs from anesthesia, exam purposes, the questions that are important here that you should be knowing is regarding thiopentone, you should be knowing propofol, you should be knowing ketamine, and you should be knowing etomidate. Basic. 4 drugs are there. When you know thiopentone, you should be knowing a little bit about methoxytol because both are barbiturates itself. So now, thiopentone, propofol, methoxytol, and etomidate, they all work at GABA receptors. All of them are working at GABA receptors. In fact, even benzodiazepine like midazolam, which is used, also works at GABA receptors. All of them. Dr. Akhilesh says no pain at the site of injection. Dr. Akhilesh, I'll come to that point. Let me finish this question, then I'll take that again. Okay? I'll take that question again. So Dr. Akhilesh has a doubt and I'll clear it in a while. So basically in that case, you have to go to the depth of how it works. So anyways, coming over the question that we are talking about, thiopentone, propofol, methoxytol, etomidate, and benzodiazepines are all working at GABA receptors. That's how anesthesia works. Basically, GABA increases, it increases the inhibition and decreases the excitation. Ketamine, on the other hand, is opposite to all of them. Ketamine works at NMDA receptor. Dr. Akhilesh has just mentioned that answer a while back. Okay, NMDA means N-methyl D-aspartate receptors. And can you see ketamine is opposite to all of them? So till now we saw this was all decreasing intracranial pressure, intraocular pressure. Ketamine was increasing on the other hand. So same ways, none of these drugs that you see, whether it is thiopentone, propofol, whether it's methoxytol, etomidate, or benzodiazepine, whether I speak of midazolam, whether I speak of diazepam, whether I speak of lorazepam, none of them have analgesic property. So therefore, all of them are working at GABA receptors. None of them have analgesic property. The only one which works at NMDA receptor is ketamine, and it has the analgesic property. And not just ketamine, anything working on NMDA receptor ideally will have some analgesic property. Other examples are, yes guys, other examples. So all the drugs that work at NMDA receptor. So from anesthesia, the works working at NMDA receptor, they are called NMDA receptor antagonist. One of them is ketamine. Other, Dr. Akhilesh says xenon. Let's good. Let us add xenon. Anything else? There are 3 and 4. 1, 2 more. And their exam point of view, all the 4 are important. Dr. Akhilesh, Dr. PK, Dr. Sushma, other people. Jaldi. Jaldi means fast. Huh? There are 2 more. Remember, out of all the inhalational agents, okay, when you speak of halothane, nitric nahi, Dr. Akhilesh, correct, nitrous oxide, absolutely correct. Yes, Dr. PK, absolutely correct. So nitrous oxide and Entonox also work, and that's why you got this analgesic property in all of them. So you find ketamine to be analgesic, nitrous oxide analgesic, Entonox also analgesic property. Thumbs up. Is it clear, everyone? That's a small way to remember. I'm not saying it's going to be the same for everything. Like how good ketamine is analgesic. Is it nitrous oxide also the same good? No. But these are the ways to remember in exam. Not everything is going to be correct, guys. But when you study for exam, we try to find correlations, easy ways. So this is one of the way to remember. Okay? So all these drugs, you see one of them is an IV drug. Other is xenon, which is still under research. And nitrous and Entonox are inhalationals. So these are all the drugs which have analgesic property. They all work at NMDA receptors. Okay? So hopefully this point is clear. Let me clear Dr. Akhilesh's doubt. Dr. Akhilesh was talking about pain at the site of injection. So for example, someone has sustained an injury. From the injury, there is, forget like this, let us put it this way. It's out of the way that, but Dr. Akhilesh has a doubt, hence I want to clear. If someone has sustained an injury, so what happens? Action potential gets generated. It gets transmitted by the nerves, basically A, delta, and C fibers. These are the slow fibers carrying it. From there, it goes to lateral spinothalamic tract, spinal cord, reaches the brain. Okay, so this is a brain pathway. You must have heard of that transmission, transduction, perception of the pain, and then, modulation of the pain also. So you people know pain pathway better than what I know. So action potential is going through this way. As I said, because action potential is the one that is carrying the sensation of pain to the brain, so when you give local anesthesia drug, what happens? This action potential, it blocks the action potential from going forward. And that's exactly, as I said, it's called a conduction block. Now, Dr. Akhilesh's question is, if you're injecting local anesthesia, does it pain? Yes, because if you're giving an injection to the patient, it is going to go inside. It is definitely going to cause pain. It is going to cause. And that's exactly the reason why people say when you're giving local anesthesia drug, also many times there's a question that comes in exam, always add soda bicarb. I think you people who are prepared for exam must be knowing this. So addition of soda bicarb helps in 3 things. So whenever you add local anesthesia, you give soda bicarb along with that, you get a better action. All right, you get a better action. You get less subcutaneous pain, because whenever you inject local anesthesia drug, the injection itself is going to cause pain. It's only that once you've injected local anesthesia, beyond that point, it is going to block the action potential. But when you're injecting it, of course, it's going to cause pain. That's the reason why we add soda bicarb. You get a better action. You get, it decreases the subcutaneous pain, which is going to be there. Plus, it provides slightly longer duration of action. Better action, slightly duration, longer duration, and less subcutaneous pain. That's exactly why soda bicarb is added. This has been an INI CET question, or AIMS question in the past. It's also been a NEET PG question. Thumbs up, everyone. Point clear? Dr. Akhilesh? Are you doubt clear ho gaya? Your doubts okay? Guys, any other question, then let me know. Okay? Dr. Akhilesh gives a thumbs up. Dr. Sushma says okay. Yes, okay. ठीक है? अरे मैं भी आज बहुत दिन के बाद क्लास ले रहा हूँ यार. Last 1.5 months even I didn't take a class. I think the last class I took was maybe in the month of December. उसके बाद से फिर even all of us were, everyone was ill in here. Everyone has got COVID. Okay, so I'm taking a class almost after 1.5 months. All right. So it's good. चाहे YouTube लो, कोई भी class लो, it's always nice. So going forward, and let's take the next question. This one we've already done. Okay, so first spinal anesthesia was given by, simple question, fast. Yes guys, first spinal anesthesia किसने दिया? Who gave? A, B, C, D. So Dr. Akhilesh, I got your answer over here. Other people? अच्छा, so let me say, Dr. Akhilesh, बाकी का answers मेरे को I didn't get, yeah. So I just waited for almost 30 seconds. So let me start. Dr. Sushma says D. Dr. PK, your answer. Didn't get as yet. Anyways, so Dr. Sushma, Dr. Akhilesh have mentioned it. Correct answer is yes, August Bayer. Okay. Remember, why is this name Morton important? Morton again has been asked in exam many a times. He is the first person to have given general anesthesia successfully. Dr. Sitaraju says D. Correct. Okay. Successful GA. Remember the drug used was ether. The year was 1846. All of them are important MCQ questions. Oliver Wendell Holmes, he coined that term anesthesia, which meant no sensation. Like in 1846, no one knew what is anesthesia. Someone was giving ether to someone and someone went off to sleep. But what is that state called? It's like when I was in 90s, when we were growing up in 1990s or 2000, you used to have a camera. But did you ever keep a camera like this and said, oh, this is called a selfie? No. Later on, in like 2005 onwards, then there's a term that came called selfie, which meant you're taking your own camera photo. That's selfie. Similarly, in 1846, no one knew what is that called. That term was called anesthesia, when they were not having any sensation. So the meaning of the term anesthesia means no sensation. This was coined by Oliver Wendell Holmes in the year 1846. Clear? So he is important because he named it anesthesia, that term, just like someone gave that term selfie. Similarly, he gave that term anesthesia. Okay. Simpson, he is the one who started using chloroform. Initially, people were using only ether for anesthesia, like Morton. So Simpson started using chloroform. Chloroform is the same thing that they show you in movies. Huh? Someone keeps in handkerchief, put on the nose, they go off to sleep. All right. This was again. So Oliver Wendell Holmes again by the year 1846. James Simpson would be year 1847 to 1849, if you remember. That this year is not important. Huh? For all these people, the years are not important. Year is important only for Morton. August Bayer, 1899, to have given spinal anesthesia. Dr. Sitaraju says tried on his son. Absolutely. Even nowadays, if you see, forget about son, but how do you start alcohol? Someone tells you, "No, chal yaar, thoda sa alcohol le, maja aa jayega. Take some alcohol, you like it." Same thing. In old times, they used to say, "Oh, I enjoyed chloroform, you also take." That's how anesthesia started, Sorry, let's not go into those details, but let's come back to what we are talking about. August Bayer. Correct, Dr. Sitaraju. Correct. All right, Dr. Bhargav Sitaraju, right. So August Bayer, guys, he gave spinal anesthesia the first time in 1899. Which brings me to one point. If you can see that general anesthesia was given before giving spinal anesthesia. And one more point that is important for exam purposes is that epidural was given even before spinal anesthesia. Epidural was given in the year 1885. Okay. So remember, the first thing to have given someone successfully was GA. Then it became local anesthesia. Then it became to epidural, and finally there was spinal anesthesia. A lot of times people get mistaken with the fact that spinal anesthesia was the first type of anesthesia given. No, the first anesthesia successful was GA, followed by local anesthesia, which was for ophthalmic procedures. Then you came to epidural, and then there was spinal. So this was 1846. All right, epidural is 1885 because ophthal was experimented for many years, and then spinal became 1899. Thumbs up, everyone, clear? That's the timeline for anesthesia. Okay, according to me. Even I may be wrong many times. I'm just sharing the knowledge that I have. So someone would say, no sir, ek saal. It is not 1885, it is 1884. It's possible it can be 1884 also. It's possible. So it's normally, that's the timeline. So let's take the next question. So please mark your answer. Dr. PK has given my answer. Other people? Dr. Sushma says D. Dr. PK says A. Anyone else? Dr. Gavya Devi says D. Correct. Chalo yaar, I was waiting. Let me give the correct answer. Dr. Akhilesh says D. Correct, correct. Who's correct? All the D people. All the people with D are correct. Okay. Remember, these are simple questions and easy questions that come in the exam. Every year, some or the other question definitely comes from cylinder. Some or the other. Whether you talk of FMGE 2021, which was in the month of August, you talk of FMGE later on. Okay. Cylinders and all these things are always there. The white shoulder one is oxygen, blue is nitrous, says Dr. Bhargav Sitaraju. Absolutely correct. So therefore, as Dr. Akhilesh says, remember, Dr. Akhilesh is not wrong. He also did think that, remember Dr. Akhilesh, you thought because of the small white patch that you see. But ideally what should happen is the shoulder should be white. So if the shoulder is completely blue with white, then this would have become entonox. Okay. So that's how you remember in exam, when you speak of colors, everyone knows oxygen. So whenever you have black with white shoulder, this is what is called oxygen. So whenever you have something with white, guys, you will have something with oxygen with that. So blue colored is always nitrous oxide. Here the correct answer is none of the above, because the correct answer is nitrous. This is nitrous. Had there been blue with white, so this would have become entonox in that case. Entonox. Similarly, you have a cylinder which is gray with white. What does this become? Let me ask 4 options I'm giving you. Okay. Is this ethylene? Is it? I'm asking you this question. A, B, C, D. Ethylene. Let's make it helium. None of the above. Gray with white shoulder. Yes, guys. Next question. I told you, questions ऐसे ही आता है. आता है मतलब हमको भी ऐसे ही आता है. We also write the same way. Dr. Sushma says one answer. Yeah. Other people? So Dr. Sushma is attending since then. Dr. Sushma attended the special class also. Dr. Sushma, good to see you here. Okay. Dr. Gavya Devi says 3. Correct. Correct. C is the right answer. Okay. So that's what? Air. So it's not ethylene, it's not helium, it is air. So gray with white shoulder is air. Right, Dr. Bhargav Sitaraju. Alright, so these cylinders are important, guys, for exam purposes. Now, next question. Which one of the following produces a non-depolarizing block? So, please, let's have the answers. These are the confusing questions. Simple questions, but slightly. You have to know the concept basically. Simple, but you have to know the concept. As it was with the conduction block. So I'm just waiting. Dr. Manoj Rishi and Dr. Akhilesh says phase 2. No, Dr. Akhilesh, that is not phase 2. Dr. Bhargav, it's not neostigmine. Doctor, that's what I'm coming to. Dr. Manoj, Dr. and someone else, Dr. Sushma. You've given absolutely correct. Dr. PK has mentioned later on. I think so. Dr. PK has given that answer. D. Correct. It is galamine. It's a non-depolarizing block. So I am speaking about muscle relaxants. Right. What does muscle relaxant do? Remember, skeletal muscle relaxants, they all work at the neuromuscular junction. They work basically at the nicotinic receptors. Okay, so these are the nicotinic receptors. These acetylcholine receptors, these are what are called as the nicotinic receptors. So as you can see in front of you, this is the nerve terminal, this is the muscle. All right, as you can see, then this part is what is called as the neuromuscular junction, where the nerve and the muscle. So when you give a skeletal muscle relaxant to a patient, or I'm giving these drugs like vecuronium, I'm giving rocuronium, I'm giving atracurium, I'm giving pancuronium, mivacurium. All these drugs basically work at the neuromuscular junction. They again are doing the same thing. They prevent that action potential which has come to the nerve ending from going inside the muscle. Therefore, if the action potential doesn't go inside the muscle, so there is no muscle contraction. So therefore, these drugs basically prevent muscle contraction, thereby causing paralysis of the muscles. That's exactly why they are called as skeletal muscle relaxants. Their only job is to paralyze the muscle. Okay, skeletal muscle relaxants. Now, all of you know that normal neuromuscular physiology. What is that? Action potential comes to the nerve ending. Then synaptic vesicles release acetylcholine. They come into the synaptic cleft. They're attached onto the receptors. Then what takes place is depolarization. And depolarization is what causes muscle movement. So what is the problem now? When you're giving drug like atracurium, you're giving vecuronium, they are giving for surgery. So that surgery of the abdomen might take place and muscle movement does not take place. So if you give drugs like atracurium and vecuronium, I don't want the muscle movement to take place. So I don't want depolarization to take place. So therefore these drugs basically ideally prevent depolarization. So there is no depolarization. Hence, all the drugs that we have, basically most of the drugs that we have in neuromuscular blocking agents, most of them are non-depolarizing. They do not cause the depolarization and therefore there is no muscle movement. And because there is no muscle movement, this is how it causes paralysis. Okay? So whether I speak of vecuronium, I speak of rocuronium, I speak of atracurium, I speak of cis-atracurium, I speak of pancuronium, mivacurium. In fact, this drug that I mentioned right now, galamine, is also non-depolarizing. Okay, whether you speak of DTC, all these drugs are non-depolarizing. Which brings me to one more point. There's another group of drugs which is called as depolarizing. So the difference is that non-depolarizing drug prevented that depolarization from taking place and then caused the paralysis. The depolarizing drugs will first cause depolarization and then they will cause paralysis. So therefore there's only one drug now that is called succinylcholine, or you can call it, it's also mentioned as suxamethonium. Okay, in the old times there was another drug called decamethonium. Nowadays decamethonium is not used, so it is out of portion, not clinically used. The only drug depolarizing now is succinylcholine. So remember, most of the drugs that you study in the skeletal muscle relaxant chapters that cause paralysis, all of them normally are non-depolarizing. So they prevent depolarization. Because of that, there is no muscle movement, because of which paralysis takes place, which is simple. Succinylcholine, on the other hand, causes depolarization and then causes paralysis. Hence, it is called as depolarizing. So someone had mentioned phase 2, Dr. Akhilesh. So succinylcholine has the one that produces two types of block. The depolarizing block initially is called a phase 1 block. And when in case it doesn't get destroyed by plasma cholinesterase, then it leads to something called as a phase 2 block. So succinylcholine is the one that produces, not decamethonium, but succinylcholine produces phase 1 and phase 2 block. Okay, and phase 2 block is basically seen in plasma cholinesterase deficiency. Thumbs up. Is it clear, everyone? So here the answer to this question that we were discussing. Morphine, it's analgesic drug, right? It is an opioid. So this is not the answer over here. Neostigmine basically is used for the reversal of muscle block. Okay, suxamethonium becomes a depolarizing block. It produces depolarizing. It is galamine that produces a non-depolarizing block. Thumbs up, everyone. Clear? Concepts clear? As in whatever we discussed. As I said, I've told before also, I don't like to discuss 100 questions in 60 minutes. I'm not of that sort. When we come and discuss 100 questions, I give you the answer and I go away. I might as well discuss with you 10, 12 questions and I discuss the concepts behind them, as I always do. That's my way. So I'm not saying this is the correct way. A lot of people might find this better, but that's how I do it. Okay, so everyone has their own choices, na? So that's my way. If I come and give you a question, I tell you how answer is galamine and I don't discuss why it is galamine, I will not be satisfied. Okay. So Dr. Bhargav has given a thumbs up, I think. Huh? I think it's a thumbs up on my phone. Huh? I don't know what it is all about, but looks like a thumbs up. Okay. Or something different. Or Dr. Bhargav has given a high five. Pata nahi hota na, we don't realize it's a high five, it's a slap, it's a thumbs up. You never know. Or it's a high. You never know. Okay, guys. Next question. So kindly identify this. You know, image questions also come. This is one of them. A commonly asked question again. Dr. Bhargav says clap. Okay, thank you. Dr. Bhargav, clap and slap. This sounds similar and they look similar on the mobile. Do you know that? Though it is correct, but that's how it looks like. Okay, so clap and slap sound similar and they look similar also. Dr. Sushma has said one answer. Dr. PK has given one answer. Other people, yeah. ठीक है, सबने आंसर दिया, right. So let's mark it correctly as all you people have said. It's a classic LMA, right? This is not a double lumen tube. You can't see two lumens out of the way. Yes, your confusion could have been between classic and pro-seal. These are the only two things. So we'll find the differences between them so that you can identify them in the exam. They can either ask you classic or they can ask you pro-seal. All right. So when you speak of classic LMA, laryngeal mask airway. So what does a laryngeal mask airway do? LMA, as the name suggests, it lies in the larynx. Can you see? This is what is a LMA. All you need to do is just open the mouth. All right. So you open the mouth, you take the LMA. This is the classic LMA that you see, the same thing which I had shown. You have to deflate the cuff. Once you deflate the cuff, you open the mouth of the patient. Can you see there is no laryngoscope used? No laryngoscope. That's an important point asked in the exam. You don't need to do anything. Just open the mouth of the patient. You slide it inside the mouth, right? Then you use your fingers, try to put it as deep as you can. At one place, you will find resistance. Wherever you find the resistance, just place it there and then inflate the cuff. Ideally, it should take the position. Can you see? It's lying here. So when you put it inside the patient, now you see it's lying here inside the larynx. Because it is lying in the larynx, it is called as a laryngeal mask airway. Okay. In fact, can you see this is the glottis or the vocal cords? It is lying above the glottis. So this is why it is also called as a supraglottic airway. Supraglottic airway means above the glottis. Important point. Remember, it has not gone inside the glottis. When you put something inside the glottis, that is more better. Okay, so you have an endotracheal tube going inside the glottis. You have tracheostomy going inside the glottis. Okay, so the biggest point of an instrument that goes inside, like for example, if I put endotracheal tube, is it better than LMA? Of course, because once you put endotracheal tube, I will inflate the cuff. Once I inflate the cuff, what will happen? Do you see it's preventing aspiration? Aspiration, in case someone vomits, stomach contents have come here. You will find it is not going inside because the cuff is preventing them from going inside. That is exactly the role of a cuff in endotracheal tube. Thumbs up everyone. Is this point clear? However, when you put a LMA in the patient, do you realize if someone vomits, regurgitates, yes, there is a cuff, I'm not denying, but the cuff is outside the glottis. That's exactly why it is supraglottic airway or laryngeal mask airway. It is not a tracheal mask airway. It's a laryngeal mask airway. It's not inside the trachea, it's in the larynx. So therefore, this stomach contents can get aspirated over here. Okay, this can cause chemical pneumonitis, ARDS, and this can be dangerous for the patient. Okay, this can be dangerous for the patient. All right. So supraglottic airway or laryngeal mask airway. All right. So the biggest problem with this LMA or supraglottic airway is the risk of aspiration. As you can see, as I have explained it to you, right? Risk of aspiration. That's exactly why LMA is supposed to be not used for IPPV. For example, you see this device, it looks like an endotracheal tube. If I'm giving breath from here, oxygen from here, so oxygen from here can go inside, carbon dioxide from here can come outside. So therefore, instead of intubation, don't you think I can always use LMA? It is such a wonderful device which is almost equal to intubation of someone. But intubation provides you the advantage that it has gone inside the trachea and prevents aspiration. LMA does not give you that advantage. Hence, intubation is used for IPPV, positive pressure ventilation. Classic LMA is not used for IPPV because the biggest problem was the risk of aspiration. So, someone said, why not put a Ryle's tube from the nose that goes here and goes inside the stomach? So, if you combine the Ryle's tube from here, both of them together, so what you can do is you can aspirate the stomach contents from here. Am I right? So therefore, now it becomes little bit safe than the classic LMA. So what did someone do? They combined both of them together. Like, let's have the classic LMA and combine them with a channel for Ryle's tube, and they made a new tube that is called the Pro-Seal LMA. Thumbs up everyone. This is what is Pro-Seal. So this Pro-Seal LMA is your classic LMA, plus it has a channel for the Ryle's tube, as you can see. Okay, so this is a classic LMA. Oxygen can go in, carbon dioxide will move out. Okay, apart from that, they have provided you with a channel from where I can insert the Ryle's tube that goes here and can go inside the stomach, and you can aspirate the gastric contents from here. Okay, So now you will see what else they have done. They've made it slightly stronger. They've given you something called as a bite block so that the patient doesn't bite. If the patient wants, he can bite this tube. If the patient bites the tube with the teeth, then what will you do? Nothing can be done. So what they've done, they've given you a bite block so that the patient doesn't bite. Plus they've made better seal compared to the classic LMA, which had a simple small seal, simple one. They've made it double seal. That's exactly why this device that you see is called as Pro Seal. It has got two seals. Okay, so apart from the front one, it's got a back seal also. These are the major differences between them. The most important being it has provided for a channel for Riles tube. It provides you with a bite block. It provides you with a better and double seal. Hence it is called Pro Seal. Most important thing, this Pro Seal LMA can be used for IPPV. Normal classic LMA cannot be used for IPPV. This Pro Seal is used for IPPV. Okay. In fact, this is the reason why Pro Seal is normally called now as a second generation LMA. So all the LMA that do not have something for the Riles tube channel is called first generation LMA. So classic LMA is a first generation LMA. Pro Seal becomes a second generation LMA because it provides you with a channel for Riles tube to go inside and for aspiration. All right. Similarly, when you speak of iGel, this iGel becomes a second generation LMA. You know, all of us are very lazy. Why lazy? Now, in this case, people start thinking, oh, why should I, inflate the cuff, first deflate the cuff, then put inside, then go inside, wherever you feel resistance, you stop, and then inflate the cuff. Okay. And what if you inflate and doesn't reach in place? If it is slightly goes up, slightly goes down, right? So, and all of us are lazy as well. So they made a new device called iGel. What is iGel now? Can you see if in the iGel there is no cuff? Can you see there's a cuff here and there is no cuff in the iGel? So cuff just has, thank you guys. The cuff just has a gel, guys. So it just has a gel. So the point is when you have a gel, you have no cuff over here. The gel takes the shape of the larynx by itself. Okay, that's exactly why you have a gel over here. Now again, same thing, oxygen can go in, carbon dioxide can come out from here, right? At the same time, they provided you with a channel for the Riles tube to be inserted that goes inside the stomach. And that is why iGel is again called as a second generation LMA. Just like the Pro Seal, it's a second generation. It is again very commonly used, especially guys during CPR, during emergency, when you are unable to intubate someone. And if you put a LMA also, Pro Seal LMA, again, you don't have to inflate the cuff. But when you speak of iGel, a device like this, you just have to open the mouth and insert it inside without having to deflate, without having to inflate. You just insert it inside the patient's mouth. It can be life-saving. And that's why nowadays iGel is so commonly used everywhere. Okay, so this is again a second generation one. The last point which was mentioned over here, which I had mentioned, was this second double lumen tube. So can you see this is 2 lumens, this is 2 lumens, but guys, this is a double lumen endotracheal tube. That is the difference. Okay, you can see 2 lumens here also, but this is LMA. This is a double lumen endotracheal tube. The difference is that it has got 2 lumens and this is basically used for thoracic surgery. Now, if someone's lung is there, okay, wait, let me just put it this way. Trachea आया, यहाँ पे divide हो गया, ठीक है, one part of the lung is here, one part of the lung is here, right? So now imagine someone is having a hydatid cyst over here and some thoracotomy is going on and you have to take that hydatid cyst out. So don't you think the infection from here can go here also onto the other lung? Dr. Munib, once again, I'll say that answer, but wait, let me just finish off the double lumen tube first. So the point is, this can go from here to here, infect the other lung. So that is exactly why double lumen tube, guys, is used in thoracic surgery or it's used in mediastinal surgery. In fact, cardiothoracic vascular surgery, I'd like to put it, CTVS and all, they use it. When you're operating upon the lung, for example, you need to do a lobectomy. You need to cut one part of the lobe and this infection should not be going to the other side. So they put a double lumen tube. What it does is it ventilates one lung, it isolates the other lung so that one lung can be operated upon and only one lung gets ventilated. So therefore, double lumen tube is also called, or something that does one lung ventilation, or it isolates the other lung. Okay, everyone, is this point clear? So DLT, remember this has been asked in AIMS exam also. DLT is double lumen tube. It is used for one lung ventilation. It's an endotracheal tube that has 2 lumens. It's an endotracheal tube, goes inside the trachea, used for one lung ventilation in thoracic surgery or mediastinal surgery. Okay. Hopefully this point is clear. Dr. Munib is asking which size endotracheal tube is used routinely. So normally, Dr. Munib, when you speak of adults, okay, in adult male, you're going to use size 8, 8.5. In a female, you're going to use 7, 7.5. Also, endotracheal tube has these various markings, right from the tube till here, how much is the tip, so you'll have markings like 22, 24, no, sorry, ulta. It's going to be like this, 26, 24, 22, 20, 18. So it is centimeters from the tip. So when you talk of a male patient, normally you have 21 to 23 centimeter at the lip. In a female patient, it's normally you keep around, nahi, ulta ho raha hai. 18 to 19 is what we keep, 19 centimeter. Nahi, zyada ho jayega weight. In a female patient, you'll keep ulta weight. Wait. I'm doing it wrong. So if you come from here, you'll have markings like this: 18, 20, 22, 24, and 26. So this is centimeter from the tip. So when you speak of a male patient, a value of 21 to 23 at the lip is for a male. For a female patient, you'll have normally 19 to 21, okay, centimeter. So this 19 to 21 centimeter will be for the female. For the male is this. Okay, everyone? Endotracheal tube also clear? Let's take one more question. So we discussed LMA, endotracheal tube also. Now, we'll take the last one for today. Then I'll come again. We'll take a YouTube session. I'll try to take it next Sunday. I think you got chutti rahega, so we'll try to take it on Sunday. Holidays all of you will have. Even I will perhaps have time on that day. And one more special class I'll take. Let's see. All of you who don't have the app, download the app, guys. So once you download the app, people who are already prepared can go through the special class. I've also told you, special class is the free class which we have. We discuss all the MCQs over there the way I'm discussing over here. But the MCQs there that we take are in the form of polls, where I understand how many people are correct, how many are wrong. As in how much clarity you people have. Kindly identify the blade. Yes, everyone. So I think most of you have given me the correct answer. So I find so many of you coming from the special class also. Today's special class. Thank you. Good to see all of you there. The ones who were on the special class today. I mean, special class on the Unacademy app. I'm finding you here again on YouTube. Nice. And do you realize, all of you who were in my special class today, do you realize my YouTube questions were totally different from the special class session? All of you. Dr. Bidisha and Dr. Sushma. Did you realize that? I think I saw both of you there in the special class also. But you see, none of the questions have been repeated there. I mean, of course, they are similar. But none of the questions have been a repeat. Okay? So I think most of you have given me a correct answer over here. That's Miller. Okay? So Miller is the correct answer. This is a straight blade that you see. A straight blade laryngoscope is Miller. This is basically used for children. Alright. The other laryngoscope that you should be knowing about is this curved blade. This curved blade is what is called as Macintosh. Important question. Macintosh is a bigger name that is used for adults. Okay. Miller is a chota naam. So this is chota means smaller, is used for children. This is a straight blade. So Miller is a straight blade that's used for children, and Macintosh is what is used for adults. McCoy is a hinge tip blade. McCoy is a hinge tip blade that is used for difficult intubation in adults or in anesthesia, I'd rather put it like this way. So as you can see, these are the 4 blades. This is what is called Macintosh. This is used in adults. The second one that you see is Miller. This is used in children. This McGill is the old one. This was the first kind of laryngoscope ever used. Nowadays, it's not used anymore. So this is what is called McGill laryngoscope. It is not used anymore, out of the way. But this is what is called McCoy. Can you see McCoy has a lever? 1 second. McCoy has a lever at the back. Here, when you press the lever, the hinge joint goes up, this hinge joint. So this is basically McCoy laryngoscope that is used in difficult intubation, especially in anesthesia. Someone having difficult intubation, we use this. Okay? Everyone, is that okay? Any questions, doubts, guys? Any questions? So I'll be glad to solve in case there's something that you have onto your mind. So we'll end the session today. Dr. Akhilesh says thank you. Thank you, Dr. Akhilesh. Thank you guys. So any questions and doubts, you can please ask me. Dr. Sushma, thank you. So people who haven't downloaded the app, please download the app. Okay. For people who are preparing. So what happens is then more of you can join us. And I've showed you before also. It's not about the subscriptions, guys. Remember, when the special class is there, this is where we discuss all the MCQs like we discussed today. All right. And plus is basically for people who are preparing long term. So Dr. Bhargav says NEET PG Unacademy. Ha, Dr. Bhargav. Yes, we'll see you there as well. Okay. Thank you, Dr. Bhargav. Happy Republic Day, all of you. Happy Republic Day. Okay. Any questions and doubts? I hope you people liked what we discussed today. And as I said, I always discuss like this, that where we have questions and where we have concepts. Remember, the questions normally will be a slight twist, but the point is to emphasize those concepts again and again so that we remember. Okay. So less questions, but more discussions is what I like, and that's how we'll discuss them out. Okay, guys. So take care. All the best. Study well. All right. You can contact us through that community. In the Unacademy app, you people must be knowing there's something called as community where you can directly get in touch with us. So on the Unacademy app, there's that community that you see. So once you follow us up, you can post up anything over there. Okay. So on Unacademy app, there's something called as community that you people can use. You can get in touch with us directly. It's just like Insta. I'm not on Insta, but on community you can find me. Okay. So take care all of you. Bye-bye. All the best. Dr. Shiva says, great teaching. Thank you, Dr. Shiva. Okay. That's exactly why we teach, That's exactly. All right. In spite of everything. So this is the reason that we teach. If you people have understood some points, it makes my day. All right. So thank you so much, all of you, for joining me at this session. Dr. Shiva says, different from others. Oh, thank you. Thank you, Dr. Shiva. अरे सबका सेम ही होता है. It's just that everyone's style of teaching is different. Okay. So everyone's style of teaching is different. Otherwise, people are the same. Don't worry. Okay. So guys, just follow me up, and then till next time, more MCQs, and then we'll discuss. Bye-bye.